very pretty cystic lesion of the liver. This was a young woman in her 30s, and this turned out to be a mucinous cystic neoplasm of the liver.
Wow.
So formerly biliary cystadenoma. So it looks kind of like the MCNs of the ovary. It's got this kind of stained glass appearance with like different T1 hyperintensity and the different locules and true septations going across the lesion.
I thought you were going to say hi to your sister from Korea.
Oh, yeah.
Aarti, what was Aarti, what is the new terminology for the biliary cystadenoma? I'm sorry.
Yeah. So it's this was an MCN. This was resected. So mucinous cystic neoplasm. So it's kind of like they've in 2010 WHO reclassified biliary cystadenoma into MCN and IPNB. So they're like the similar counterparts to the pancreatic ones. So just like in the pancreas, the MCN will be lined with ovarian stroma, and so mostly in women, although it can be in men. And so it has a true capsule to it, and usually, like if it has true enhancing septations across it, then it won't be a hamartoma. But there can be some that like overlap with hamartoma. So when you get these large lesions and they start getting more complex, there is like overlapping features between just a biliary hamartoma and a MCN. And then the other one that biliary cystadenoma was classified into was IPNB, or intraductal papillary neoplasm of the bile duct. So that's like papillary fronds that are growing in the bile duct. You can't really differentiate it from an intraductal cholangiocarcinoma, but it overall has a better prognosis. So like after it's been resected and been diagnosed as an IPNB, those patients have a better prognosis than cholangio.
Thank you.
Does that make sense?
So that was resected?
Yeah, perfect. Thanks.
Yeah, so this was resected and it had low-grade dysplasia, but it did not have invasive adenocarcinoma. And these liver MCNs, they think actually tend to be more indolent and kind of like low-grade. But yeah, this one did not have invasive adeno. And the other interesting thing I learned is that the ovarian stroma is not homogeneous throughout the capsule. So we had a couple of cases where we were like hedging on it. We weren't sure if it was a hamartoma or an MCN. It didn't have like these real locules and septations in it. And we were asking them like, okay, like don't fenestrate it, but maybe at least do a frozen section in the OR. But they have to get frozen sections of multiple areas because the ovarian stroma can be patchy.
Hmm. And do these patients require surveillance?
After they've been resected?
Yeah.
Yeah, I presume so. I think the etiology is thought to be the same, where it's a piece of the ovary embryologically that's left either on the tail of the pancreas or in the left lobe of the liver.
Yeah.
So I don't think it's like a field defect as far as like the entire biliary system, but presume that'd be certainly.
Very neat.
Mm.
And even the intraductal papillary biliary neoplasms, they can also have dysplasia. And they can also have this range of spectrum from dysplasia to cholangio as well.
Yeah, that one seems like it'd be more of a field defect, like that you'd really need to surveil the whole system over their lifetime.
Yeah.
But even like these pancreatic MCNs with low-grade dysplasia, like they often don't, get recurrences or anything like that. So they're actually starting to do active surveillance of some of those, the small ones, like less than 3 centimeters, kind of putting them into like the IPMN category.